So we'll continue our look at cardiovascular abnormalities by looking at the cardiac dysrhythmias, Im- improper beating of the heart, things that throw off the cardiac cycle. Now, it's the cardiac rhythm, as you may remember, is really controlled by the autorhythmic cells, uh, and it's modified by external sources. And all of these things can screw up and give you some sort of a dysrhythmia. So there's three major types of dysrhythmias. One is abnormal rates of the SA node. Um, so it's firing too fast, too slow, inappropriately, irregularly. So it would be some sort of abnormal sinus rhythm rate, and that's generated the SA node. Another is ectopic impulse initiation. So impulse is not being generated by the autorhythmic cells of the sinoatrial node, but from someplace outside of that. And the third type is some sort of disturbance with the conduction system, with those specialized cells that are the non-contractile conducting cells in the myocardium. Um, and so they can disturb. They can fire too soon. They could be blocked. They could be cut. They could be they could be dead, and that's all going to lead to some sort of dysrhythmia. Now, why does this matter? Well, a normal rhythm is important for proper cardiac output. Um, so, so this can lead to a lot of other problems. Now, the dysrhythmia might be the result of another pathological disorder. And so, uh, with the ease of electrocardiograms, looking at this may um, may indicate or show another pathophysiological disorder. Not to mention, and as I already said, it impairs the normal cardiac output. It impairs the functioning of the heart. So this slide is really just a quick review of the things that we talked about in AMP. That the rhythm starts at the SA node, uh, passes through the atria, spreads through the atria, kind of at the internodal pathways, uh, then fires the AV node. The AV node passes down through the AV bundle and the right and left bundle branches and out the Purkinje fibers, and they cause depolarization of the myocardium. And so and then they have to repolarize to fire again. And we in the lab last year we looked at ECGs, and we discussed P, QRS, and T waves on the ECG. We looked at the various segments and different parts, and I'm not going to take the time to review that now. But if you need a refresher, go back and look at your notes or look at your physiology textbook, or there's lots of YouTube things about the conducting system of the heart and maintaining a normal rhythm. But it is good at this point to maybe pause this and go and remind yourself that the P wave is the depolarization of the atria just preceding atrial contraction. QRS is the depolarization of the ventricles and the repolarization of the atria, just leading to ventricular contractions, ventricular systole. And the T is the repolarization of the ventricle and therefore relaxation of the ventricle. So the normal sinus rhythm is kind of this thing all working properly. So it's a heart rate of between 60 and 100. You kind of depending on what shape you're in, etc., what kind of cardiac output is being demanded at the time. But importantly, the rhythm is pretty regular. If you remember from the lab, randomly we sampled 4 different sites, and they were all within a couple of milliseconds of each other. The T to T intervals that we looked at. So you want to see this regular rhythm. You can sense it as you're taking a pulse. You want to see that the P wave precedes the QRS, so that the atria depolarizes before the ventricles do. You want to look at the regular PR intervals, the QRS time, the QT intervals. All of this has to be of normal duration and for it to be considered a normal sinus rhythm. And a lot of goals of treatment are to see this normal sinus rhythm. And it will be charted as such, normal sinus rhythm. So some of the simplest dysrhythmias originate in the atrium at the SA node. So we call them atrial dysrhythmias. And that really is the heart going too fast, the heart going too slow. Tachycardia is too fast, bradycardia is too slow. So sinus tachycardia, and it's sinus tachycardia because it originates in the SA node, the sinoatrial node, is abnormally fast heart rate, greater than 100 beats a minute. Now, this could be compensatory to needing more cardiac output or maintaining cardiac output allostatically when stroke volume goes down for whatever reason, because of a loss of contractility, loss of the myocardium in MIs, that kind of thing. Or it could be increased demand, increased tissue demand will call for an increased cardiac output, which will then be calling for allostatically a tachycardia. If this is pathological, then you're gonna treat it. Now, really, to treat it properly, you have to look at what's the underlying cause, and you have to address the underlying cause. So if it could be that that cardiac output is down because stroke volume is down, so they will treat with different things to try and bring the stroke volume up. But to address the tachycardia, really you can either block the sympathetic nervous system, because sympathetic nervous system speeds up heart rate, so you can look at these sympatholytic agents, or you can look at calcium blocking channel blockers, and that changes the rate at which the contractions happen. It's just as simple as that. Bradycardia is the exact opposite. It's when the heart rate's lower than 60. Now, there are a lot of athletes that are lower than 60 because they're extremely well fit, like cyclists and endurance athletes, marathon runners may have a resting heart rate of 50 or lower. I think Lance Armstrong had a resting heart rate of 45. So in physically fit people, bradycardia is the norm. So if you've got a patient that you're caring for and you look at him in the bed and he's obviously a fit guy, don't worry too much if the heart rate's lower than 60. But at the same time, if the next bed you go to and there's an elderly man who's obviously in not physically fit shape, and you see less than 60, that might be indicative of something pathological. The big problem with the slow heart rate is that it can lead to low cardiac output. Now, paradoxically, in fit people, the slow heart rate increases the time for filling, which increases stroke volume, which actually increases cardiac output, uh, which is kind of the cause of the slow heart rate. But in everyday people, its main kind of cause, or the main thing that happens, is lower cardiac output, and that can be dangerous. You're just not delivering blood the way it needs to be delivered. So you treat it by either mimicking the sympathetic nervous system, so the sympathomimic drugs, or you can block the parasympathetics with the lytic drugs there. So either way, you end up increasing the heart rate by decreasing the vagal stimulation of the heart or increasing the sympathetic stimulation of the heart. Now, sick sinus syndrome is when the SA node isn't functioning properly, and it will alternate between periods of bradycardia and tachycardia. This can really throw off, raise cardiac output, lower cardiac output, right? So it can raise filling and lower filling. It can set the rhythms all askew. And so the treatment for that is a pacemaker. Now, my mother last year ended up with a sick sinus syndrome, and she had to have a pacemaker put in. And what was happening with her was that her blood pressure would bottom out, and then because of low cardiac output, and then it would skyrocket, and it became a dangerous thing. I mean, she lost consciousness because the blood pressure dropped so low. She had dangerously high blood pressure at other moments. The pacemaker helped deal with that. Okay, so another thing that can happen in the atria, so it's considered as an atrial dysrhythmia, but it's not from the SA node, is an ectopic cause for the atria to depolarize. So this is premature atrial complex, PACs. They generally have a normal QRS, but the atria is contracting inappropriately, which is going to affect ventricular filling, and it's going to affect cardiac output, but not really affect the QRS, cardiac or ventricular systole. The big thing about PACs is they may be precursors to other more serious dysrhythmias. They might be more of a warning sign than a problem on their own. So they have to be well noted. There's some underlying pathophysiological process that will be causing them, and those processes may accelerate to something more serious or something else. Now, atrial flutter, and you may have seen this already in your practicum, is where the atrial rate goes way up. It's like an atrial tachycardia without the rest of the heart following suit. So atrial flutter is this rapid atrial contractions rate of like over 200 beats per minute. And now it's going to have a profound effect again on filling, on atrial filling, and therefore ventricular filling. And in this whole preload portion of it, therefore, it's going to decrease stroke volume and decrease cardiac output, which will probably be allostatically compensated for by an increased heart rate, and which may actually exacerbate the problem. Um, so this is definitely a pathology. It's something that shouldn't be going on and needs to be addressed. Now, AFib, atrial fibrillation, is just a disorganized, irregular rhythm. So in the flutter, there still is that wave of systole, the atrial systole, and the atrium is contracting as a unit. In fibrillation, parts of the atrium are contracting while other parts are relaxing, and so you end up with very little pumping. You just move blood around within the atrium. It's going to have a huge effect on ventricular filling and therefore on cardiac output. And often this can accelerate to become other issues. Okay, so the ventricular dysrhythmias really will start out with premature ventricular complexes. So this is contraction, systole of the ventricles before it's supposed to happen. And this is arising from the myocardium itself rather than from the AV node or the SA node. It's in the myocardium and it's in the ventricle. It doesn't go backwards to depolarize the atria. It doesn't activate that way. Oftentimes, you'll get this premature, and then you'll get a little pause because cardiac output's gone way up, and then it pauses and then comes back. If it gets high enough, and it's happening before filling happens, then stroke volume goes way down, because if there's a ventricular systole that's happening at about the same time or even faster than the atria can fill, then preload goes way down, so cardiac output goes way down. So cardiac output can be severely compromised with PVCs. And it needs to be attended to quickly. Now, ventricular tachycardia is very, very serious. The ventricular systole happens at greater than 100 beats a minute. Now, and only the ventricle. And this is as opposed to just tachycardia. So you get these really wide waves in the ECG. The P waves are buried in it if they're happening at all. There's no filling, no chance for filling. So cardiac output is severely affected, and this can be fatal just because it is so disruptive to cardiac output. The systoles just come right on top of one another, and the heart stays contracted for longer than it should. Ventricular fibrillation, VFib, is when different parts of the ventricle is contracting while other parts are not. And so what ends up happening is the blood just gets sloshed around within the ventricle. Like the contraction just moves the blood from the contracting part of the ventricle to the relaxed part of the ventricle, and then when that contracts, the part that had contracted before is now relaxed, and the blood just sloshes back. You get this quivering motion and the blood doesn't get, like, the ventricle doesn't develop enough pressure to actually open the semilunar valves, and there's little or no ejection. Um, Cardiac output basically ceases. We get no really identifiable QRS complexes because different parts of the myocardium are depolarizing at different times, so the overall depolarization just gets messy. Um, you can't identify like a pattern to it. This will lead to death, and quickly lead to death. So this is why we have defib machines, defibrillators. There's one at the bottom of the elevator in M building uh, for this very reason, because it has to be reversed. Now, what a defibrillator does is by electrically opening all the voltage-gated sodium channels, it depolarizes the entire myocardium simultaneously, and presumably then it will go through the it will go through the period where it's reestablishing the resting membrane potential with the sodium potassium pumps. All the myocardium will do that simultaneously, and therefore will start to depolarize synchronously again and reestablish a normal sinus rhythm. It's interesting that when you do that electric shock also opens all the voltage-gated channels in the skeletal musculature, and that's why the person ends up arching their back, and because the erector spinae muscles will fire at the exact same time. But the whole idea is kind of just to reboot and get everything back in sync. Now, the pathway disturbances, so this is through the intrinsic conduction system, can really include delays. Now, remember that there's normally a small delay at the AV node before the bundle of His, and that's normal, and it's important that it be there. But if that delay extends, it can lead to problems. It's going to lead to dysrythmia. There can be blocks in the pathways where conduction just ends or is very difficult. There could be abnormal pathways where there are electrical connections where there's not supposed to be, and that's generally got something to do with congenital anomalies. We see that when there's other congenital anomalies more than in a normal healthy heart. You don't tend to develop abnormal pathways in an adult heart that was previously normal, but you do develop delays and blocks, and that comes from ischemia and or infarctions. So and some of the stuff that we talked about in the previous video can lead to these blocks and prevent recovery to normalcy at post-infarct. Okay, so we'll talk about the blocks. Um, so there's disturbances between what's going on in the atrium and the rhythm that's set by the pacemaker cells in the SA node, and the response of the ventricle. So when is the ventricle going to contract? So we break that down into first, second, and third degree blocks. So the heart block could be either a delay in the conduction, or it could be a complete stoppage of the conduction. And this normally happens when we talk heart blocks. It happens in the either in the AV node or in the bundle or in the bundle branches. But when we talk heart block, it's the bundle. We'll talk about bundle branches momentarily. A first degree block is there's a delay at the AV node, and so the PR interval on the electrocardiogram gets long. You get an increased time between the atrial contraction and the ventricular contraction, so there's a delay, kind of post filling. A second degree block is when that gets even longer, and it can get to the length where you're going to miss ventricular contraction. Now, if the delay is so long that the atrium is ready to contract again and the atrium contracts again, you get another P wave before you get the QRS, and therefore T, and so you actually miss an entire ventricular contraction, and that's a second degree block. A third degree block is often called the total block, a total heart block, and there's no transmission from the atrial to the ventricle, and the ventricles don't get stimulated, and so therefore don't contract. Cardiac output goes way down, and this, depending on the severity of it, can lead to syncope, or probably far worse. Now, obviously, if it's only leading to syncope, the third degree block is not on every depolarization. Now, the abnormal pathways usually are congenital, and they are often associated with the physical congenital anomalies, like some of the septal defects and things like that. The problem with them is that the accessory pathways and the alternative pathways may be shorter and lead to early depolarization. There may not be a delay at the AV node, and the kind of the PR interval gets really short, and the ventricle starts to contract before the atrium is finished and repolarizing. So this will have impacts on cardiac output through altering stroke volume because of preload. The bundle branch blocks are just what it sounds like. So the block happens in the left or right bundle branch. The right bundle branch is the right ventricle, the left bundle branch is the left ventricle. The problem with this is if there's a delay in the one, then the one ventricle has its systole at a different time than the other ventricle. And so there's a delay, which can lead to kind of funny filling of the lungs before the systemic. So it makes for an unsmooth circuit, basically. Now, obviously, the left one is more because it is more serious because it pumps systemically, and the right one just is pulmonary. There's much less work to do through the pulmonary. Now, the other thing about the left one, and you have to remember with all of these things, when there's a decreased cardiac output, that also means a decreased perfusion to the myocardium itself, which then is a stressor to the heart, and so can therefore exacerbate any problem that's going on. So the blood to the myocardium is affected by things that affect the left side. Now, you've probably dealt with in practicum people with bundle branch blocks. There was actually a nursing student, I think in the class ahead of you, maybe two ahead of you, that had a right bundle branch block, kind of post an ischemia, they think. So a lot of these people can function fairly normally. They just have to be aware and compensate. Okay, so now we're going to talk about blood pressure, and we're going to specifically talk about arterial blood pressure, which really has got to do with left side and systemic arterial blood pressure. So really, what is blood pressure? It's caused by the systole of the left ventricle, and it's what moves the blood through the system. And it really is the difference between the pressure in the left ventricle at systole and in the right atrium. Now, we can say that that pulmonary blood pressure is the difference between the right ventricle in systole and the left atrium. Same deal. But for arterial blood pressure, left ventricle systole to right atrium filling. 120 to 0, because as the blood comes through the vena cava, there's virtually no pressure left. So in order for the systole has to overcome the diastolic pressure of the blood, which is really about the amount of blood that's in the space and about the elasticity of the elastic arteries. And it has to overcome that diastolic pressure as the afterload in order to have the aortic valve open and have ejection and cardiac output. So so that brings us to a definition of what's pulse pressure. Pulse pressure is the difference between the pressure at the time of systole and the pressure at the time of diastole of that ventricle. So we call it systolic blood pressure and diastolic blood pressure, but really systolic is the blood pressure, the pressure in the arteries at the time of ventricular systole, and diastolic blood pressure is the pressure at the time of systolic diastole. Now, back in A&P, we presented a formula that said cardiac output is delta P over R. Blood flow was delta P over R, the difference in pressure over the vascular resistance. Now, if you rearrange that same formula, so that we looked at cardiac output or flow out of the heart is the opposite to resistance. More resistance, less flow. Less resistance, more cardiac output. But if we rearrange that same formula so that it's like CO equals BP over R, we come up with BP equals CO times R. So blood pressure is really the cardiac output times the systemic vascular resistance. that means that if resistance goes up, then blood pressure goes up. It is proportional. It's directly proportional as opposed to inversely proportional. So systemic vascular resistance goes up, blood pressure goes up, and if cardiac output goes up, blood pressure goes up. If cardiac output and resistance go up simultaneously, blood pressure goes way up. So it's directly proportional to both the factors. So this is all just a review of the A&P, but so I'm not going to go into depth with it. But really, the determinants therefore are cardiac output and systemic vascular resistance. So cardiac output is the stroke volume times the heart rate. The stroke volume is how much blood leaves per beat. The heart rate is how many beats per minute, and the cardiac output is blood per minute. So anything that increases heart rate will increase CO, which will then increase blood pressure. Anything that increases stroke volume will increase cardiac output, which will increase blood pressure. Anything that increases vascular resistance will result in an increase in blood pressure as well. The things that cause vascular resistance are the length of the tube, the viscosity of the blood in the tube, and the radius of the tube. The main thing being the radius and the compliance of the tube. In long term, gaining weight means that you have a longer tubes, therefore increased vascular resistance, therefore increased blood pressure. That's why you tell people lose weight, and it will help lower your blood pressure. That's why heavy people tend to have higher blood pressure, etc. Now, the stroke volume really is the difference between the end diastolic volume, which is the maximum filling of the heart, and the end systolic volume, which is how much is left in the heart at the end of systole. So the amount, the difference is what's ejected, and that's the stroke volume. So anything that increases the end diastolic volume will increase cardiac output. Anything that decreases the end systolic volume will increase stroke volume and therefore increase cardiac output. So all of these factors all come together, and we spent a good deal of time in A&P talking about this, and you probably spent a good deal of time in health assessments talking about it as well. It's one of the main reasons that we take blood pressure on virtually everybody, because there is a lot of information there, because there's so many factors that are involved. It really behooves you as healthcare practitioners to understand the interrelationship of all of these factors and how they ultimately affect blood pressure, which is one of the primary things that we look at when we're assessing people. So the blood pressure is regulated by renal factors, neural factors, hormonal factors. So it's the kidneys, it's your brain, it's your endocrine system, right? And it's going to change, and it's going to change all the time depending on circadian rhythms, on demands. Just if there's more demand, then we need more pressure. Right? Now, so it's regulated in a kind of short-term and long-term methods. Short-term in seconds or minutes, and most of the short-term regulation is through the sympathetic nervous system, through epinephrine and norepinephrine. Sympathetics increase contractility of the heart and therefore increase stroke volume, which increases cardiac output, which then increases blood pressure, or it increases heart rate, and it increases heart rate, which increases cardiac output, which increases blood pressure. Now, it also is involved with the vasomotor center, and baroreceptors then feed back to the vasomotor centers. So the baroreceptors are the cells that are actually monitoring blood pressure, and the vasomotor center will either activate alpha receptors in the smooth muscle walls of the arterioles, or it activates beta receptors, beta 1 receptors in the heart. So if the alpha 1 receptors are activated, then you get vasoconstriction, and vasoconstriction increases peripheral resistance. Increasing this resistance, therefore, increases blood pressure. Beta receptors are the receptors in the heart that increase cardiac output, increase contractility and heart rate, and increase blood pressure by increasing CO. Now, this is reflected in the drugs that we use to help regulate blood pressure. So alpha blockers reduce peripheral resistance, stop vasoconstriction, and will help manage blood pressure that way. Beta blockers decrease cardiac output and lower blood pressure that way. And then there are drugs that are both alpha and beta blockers that work in combination for that. And these are tools to help manage blood pressure issues. This slide really is looking at this exact same information in a kind of more of a graphic way. So the short term changes from minute to minute. It almost changes heartbeat to heartbeat. The long-term regulation really is about managing how much fluid is actually in the vascular system, and so in the whole extracellular space. If there's more fluid, then we have more blood pressure because we have more fluid in the same amount of space. Now, we can get more fluid by increasing the osmolality of the serum sodium, and then what that'll do is that'll make the pituitary release antidiuretic hormone, which will bring more water to dilute that increased osmolality of the sodium, and that more water increases the volume, which increases the blood pressure. Now, the renin-angiotensin-aldosterone system is really a big important regulator of blood pressure. Renin is a hormone that's released by the kidneys in response to not enough pressure for effective glomerular filtration. The renin causes angiotensin, or angiotensinogen, to turn into angiotensin 1. Now, angiotensin 1 doesn't have a direct effect, but angiotensin 1 converts to angiotensin 2 using an enzyme called ACE, angiotensin converting enzyme. So ACE makes angiotensin 1 become angiotensin 2. Now, angiotensin 2 has two important effects. One is that it causes the release of aldosterone, and aldosterone turns on the sodium-potassium pumps of the distal convoluted tubules in the nephron and increases the amount of sodium. That increase in the amount of sodium will increase the osmolarity, which will then cause the pituitary to release antidiuretic hormone, open the aquaporin 2s in the distal convoluted tubules, and increase the amount of water that comes back, and therefore increase the volume uh, uh, and increase the blood pressure that way. And angiotensin 2 also is a potent vasoconstrictor, and by vasoconstricting, it will increase blood pressure. So this is very useful at raising blood pressure. Now, again, this is a schematic diagram of that. Now, we also need to be able to lower blood pressure. In this long-term regulation, it's not enough just to assume that that blood pressure is going to be low and we need to raise it. Blood pressure is sometimes going to be high and we need to lower it. Now, the increased amount of blood volume causes increased filling and actually stretches or dilates the atria of the heart. The atria of the heart responds to this dilation by releasing a protein called atrial natriuretic peptide. Now, atrial natriuretic peptide literally means, when you break down the word, protein that puts sodium in your urine. Protein from the atrium that puts sodium in your urine. So it makes your pee salty. It causes you to increase the excretion of sodium. By increasing the excretion of sodium, you're also going to increase the secretion of water, because the water is directly linked to the osmolarity of sodium. It also will have an effect on the glomerular filtration rate, so that things move a little bit faster. Ultimately, it means that your pee is saltier and more dilute, which then reduces the volume in the vascular space, which then lowers blood pressure. And we're actually just going to skip over the intrarenal arterial constriction. This slide makes it seem backwards. And it's really not an important mechanism. So we're going to worry more about the atrial natriuretic peptide, because this is not reabsorption, it's excretion. So this looks at the angiotensin thing. So if we look at this, the angiotensin converting enzyme is integral to this step, which then leads to all of this, to increase blood pressure. There are a class of drugs called ACE inhibitors that break the chain in this step and or therefore help manage blood pressure. Okay, so hypertension is high blood pressure. It's a really common thing. It's there can be primary hypertension, which the hypertension is the problem, or there can be secondary hypertension, in which the hypertension is caused by a different thing. Now, primary hypertension is kind of the most common primary diagnosis in probably the entire Western world. This is the United States because our books tend to be American, but it's just as high in Canada and Europe and etc. The sequelae of primary hypertension is increased morbidity and mortality because of heart disease, kidney disease, peripheral vascular disease, strokes. Right? It's saying it's responsible for an annual worldwide death rate of 7 million people. That's more people than died in World War I. It's a huge number, and so there's really an epidemic of primary hypertension. And that's too bad because it's an idiopathic disorder. it's really common, and we don't know what causes it. Now, it's a problem of adults. You don't see this in kids. If you see hypertension in kids, it's probably secondary hypertension, surrounding something else. There's various subtypes. So, isolated systolic hypertension is when the systolic number goes really high and the diastolic number doesn't. Isolated diastolic is a very high diastolic with fairly normal systolic numbers. Most of them are combined systolic diastolic hypertension, where both of them are elevated. And systemic blood pressure issues will lead to cardiovascular disease, which then exacerbate the hypertension or have an effect on it. Like a lot of the causes of problems surrounding primary hypertension are really allostatic. It's about trying to compensate and return to homeostasis with it. But unfortunately, a lot of the allostatic compensations result in blood pressure changes. So it can be really self-perpetuating in a way. So even though it's idiopathic, we have identified risk factors. So predisposing factors, as it were. So there's the non-modifiable ones, age and family history, because you can't change that as much as we'd like to change age. Many of us would like to trade families too, but that's not modifiable. The modifiable ones are the ones that all the medical advice surrounds. So this is dietary factors, especially surrounding sodium intake, sedentary lifestyles, obesity, and metabolic syndromes of inappropriate insulin and fat levels in the blood. These are can include type 2 diabetes or pre-diabetic syndromes, things like that. But all of those things are modifiable. Now, with that said, many patients have comorbidities. A very good friend of mine who was always very athletic, was always had good blood pressure and good health, has developed COPD because of smoking, which is a modifiable factor, but he has modified that. And the COPD came after he quit smoking, so it was too late. But because of the COPD, he's unable to exercise. Because of the lack of exercise, he's become more sedentary and has put on some weight. The extra weight means increased blood pressure to overcome the increased peripheral resistance. The sedentary lifestyle makes it difficult for him to lose the weight. Dietary factors, he's trying to modify. He tries to watch sodium and things like that, but that can be very difficult. Because of the lack of exercise, because of the COPD, he's also starting to get elevated blood sugars. And so where we'll say those are all modifiable things, he would argue that it's not really modifiable to him because he doesn't have the wind to exercise, to decrease weight, to get away from the sedentary lifestyle, and to control his blood sugars as effectively. So the only thing that he really has is dietary factors. And I'm just mentioning this to say, okay, from a strict point of view, we are talking about modifiable, but many of our patients are going to have comorbidities that make these things very difficult to deal with. Now, this chronic hypertension really means that there's going to be a big afterload. So the big afterload means that the heart's going to have to work more. That heart working more is going to result in myocardial disease. Could be myocardial hypertrophy, and then that decreases the size of the ventricle and stroke volume, etc. And ultimately, it can lead to heart failure, like we talked about in the previous videos. The increased blood pressure means that the kidneys, especially at the glomerular level, will have too much pressure, and those are very delicate tissues, and that can actually lead to scarring or issues at the filtration membrane at the glomerulus, and can lead to profound kidney damage and ultimately kidney failure. The retina of the eye is very highly vascularized, and it's very important that it be highly vascularized, but the capillaries are very susceptible to damage from pressure. Little hemorrhages and things like that are very damaging to the retinal cells, even after the hemorrhage has been cleaned up. The nerve cells that are there are damaged and don't come back. So it can lead to blindness. And last but not least is that the cerebral vasculature is put at risk with high blood pressure, and aneurysms can pop, or and they can lead to stroke via hemorrhage, especially if there are some baryaneurysms and things. And that's got to do with family history and age. So the outcomes of hypertension can be really quite severe. Now, one of the problems that we have with educating patients and educating the public about the risks of hypertension, we can say things like 7 million people a year die of primary hypertension, and people think, well, I've never met anybody that died of high blood pressure. That's because they don't die of high blood pressure. They die of kidney failure. They die of heart failure. They die of stroke. And so that's what the relatives and the survivors and the friends know. It's like, George died of a stroke. Mary died of kidney failure. What they don't see is what caused the kidney failure or the stroke or the heart failure is primary hypertension, an idiopathic, largely preventable disorder. So this chart is hypertension and atherosclerosis. Really, it's here for the hypertension part, but atherosclerosis and arteriosclerosis in general. Atherosclerosis is the plaque formation. Arteriosclerosis is hardening of the arteries and hardening and thickening of the arteries. Both will increase blood pressure because the compliance of the blood vessel goes down, so it increases peripheral resistance, which increases blood pressure. So hypertension and atherosclerosis, arteriosclerosis are linked. So that leads to problems with the heart and arteries, increased myocardial work, hypertrophy, which can lead to heart failure, increased myocardial demand of oxygen, which can lead to angina, or acute coronary syndrome, unstable angina, which can lead to heart failure. The pressure can lead to aneurysms developing in the blood vessels, which then can lead to hemorrhage, etc. It damages the kidneys, kidneys regulate blood pressure, so damaged kidneys results in more hypertension, which then can go way up. Autoregulation failure leads to hemorrhage, end-stage renal failure, ischemia. Um, it's hard on the brain, increased pressure. You can end up with hemorrhagic stroke, transient ischemic attacks, ischemic stroke, retinal detachment, retinal hemorrhage. And all of that can lead to blindness. All of these things, very real and unfortunately very common. Now, secondary hypertension is hypertension, and it has the same manifestations, but it's not idiopathic, but rather it's a sequela of other diseases. When we see hypertension in kids under 10, it is likely secondary hypertension. So it's usually related to kidney disease. Everybody on dialysis has to take blood pressure medication because they will have a secondary hypertension, because the kidneys are just regulators of blood pressure, the long-term regulators of blood pressure. Coarctation of the aorta, so that's a congenital problem around the ductus arteriosus, where there's a narrowing, and so that will lead to hypertension to try and overcome that coarctation. Pregnancy can lead to a secondary hypertension, and it actually can be quite scary. Obesity, sleep apnea, things like that. So when you have sleep apnea, you have less saturation of oxygen in the blood, which means that more blood has to be delivered to deliver the same amount of oxygen, which necessitates increased blood pressure. Obesity means that there is more tissue to be fed. The tubes are longer, increases in peripheral resistance, and therefore increases blood pressure. Endocrine disorders are often involved, so things that are involved, cortisol or ADH, like the paraneoplastic syndromes, like in the case study that we looked at. All of those sorts of things can lead to hypertension, a secondary hypertension, which then leads to the same morbidities and comorbidities that that primary hypertension goes to. So if you have secondary hypertension due to renal disease, then the problem is that the hypertension will lead to more renal disease, and can be very counterproductive. Now, pregnancy-induced hypertension, PIH, is also called toxemia or preeclampsia, eclampsia. I tend to know it more as preeclampsia rather than pregnancy-induced hypertension. And I think that's often the institution that you are educated at, or the institution that you're working at, what is the favored descriptor of it. They're all the same thing. This is the problem I have with the pregnancy-induced hypertension name is that it focuses on the hypertension, where the preeclampsia kind of spreads all the other things that may be involved. Toxemia means toxic blood. That's a bit of a misnomer. It's the old-fashioned name, and a lot of the lay public know it as toxemia. But basically what happens is hypertension happens in pregnancy, oftentimes because the increased workload and the increased resistance of putting blood through the placenta and and nourishing the baby. The results of pregnancy hypertension, preeclampsia, can be things like premature labor, abrupted placenta, abruptio placentae, placental abruption is the more common way to say that, and that is really a premature detachment of the placenta. Usually happens during labor, which is definitely not good for the baby because the baby can't breathe because he's not born yet, and the placenta detaches that can lead to fetal distress. There's a thing called disseminated intravascular coagulation, and this is because of the hypertension, the tunica intima all over the endothelial cells all over stop their ability to prevent coagulation. So you ended up with these small coagulations everywhere. But the problem with that is that you're limited to the amount of fibrinogen that you have and the clotting factors that you have. So there's a paradoxical increased chance of hemorrhage because you've used up all of your clotting factors needlessly. So it's a paradoxical thing. It's not so much that you're developing clots and that may be embolized, but more it's using up resources. Hemorrhagic stroke, that literally means that you blow aneurysms in your brain from the increased hypertension. Liver failure, acute renal failure, like sudden acute renal failure, all can happen because of this. So toxemia, preeclampsia, eclampsia is really a medical emergency, and a lot of times that results in really early cesarean section to try and prevent this from getting further, because it can have some very serious consequences on both the mother and the baby. So what happens here? Arterial pressure goes up, and it goes up really rapidly, and then that affects the kidneys, and when it affects the kidneys, so you get these fibrinoid almost scarring in the glomerular membranes. Then the glomerulus becomes leaky to proteins, and you lose albumin, and you lose large amounts of the protein into the urine, which then screws up the osmotic gradient between the interstitium and the vascular space. So you don't draw as much back. It's the drawing power back into the capillaries is lost, and so you end up with an edema, amongst other things. So who gets this? Really young mothers and really kind of late mothers. People that are carrying twins are more prone to it. People that have hypertension pre-pregnancy are more prone to it, because the pregnancy will put extra load. People with cardiovascular disease or renal disease pre-pregnancy, again, diabetes will do it. Sometimes diabetes of gestation, sometimes it's type 2 or type 1 diabetes that are pre-pregnancy. So all of these things can be predisposing factors. Now, not everybody with the predisposing factor will end up with the pathology, and that's an important consideration. Not every woman that's 40 years old having a baby is going to get preeclampsia, eclampsia. Not every 14 or 15-year-old having a baby is going to get it. It's just that they are more at risk. And there's really no way to know beyond the predisposing factors, because we don't know what the triggers are. And I think the triggers are different in each person. I think that the old saying that genetics loads the gun and environment pulls the trigger. I think there's predisposing factors, and there's family history and the way that your body allostatically compensates to things, which is your nature rather than your nurture. And then add something like poor nutrition or an immune insult. Uh, like you might have an oversensitive immune and maybe an allergic reaction to something or food poisoning or something like that might set off the, the cascade into this. But fundamentally what happens here is that you end up retaining too much sodium and therefore water. There's a huge weight gain really quickly and you get an edema. And you lose the proteins in the glomerulus, and that all just adds up and becomes really quite a serious condition. Okay, next topic is shock. Now, shock, you hear this a lot. A lot of people suffer from shock. Really, what shock is a group of different conditions that are all lumped together under shock. And what they have in common is that there's a hypoperfusion of blood and or an impaired ability of the cells to use oxygen. So really, it's about not delivering oxygen. It's about creating ischemia, and it's usually got something to do with hypoperfusion, about not delivering blood to the tissues as required. Now, this can happen because of a decreased cardiac output and therefore a decreased blood pressure. It can happen because of a maldistribution of blood flow, so that that blood ends up not where it's supposed to be, and that can even lead to a big drop in blood pressure and therefore loss of perfusion everywhere. Like for instance, heat stroke or sunstroke is you are trying to radiate heat to the point because you're overheating, you dilate all the blood vessels in your skin to try and bring that heat to the surface and get rid of it. But in doing so, you lower your whole systemic blood pressure because you are bringing too much blood to the skin and you're taking it away from everywhere else. So you only have so much blood to go around, and so pressure drops. It can also happen because of reduced blood oxygen content. So that could be from like secondary to breathing disorders or being in environments with low oxygen, or it could be anemia, it could be the ability to deliver. Yeah, it's like all of those things that we talked about in the respiratory can lead to this hypoperfusion and lack of oxygen. So if we look at kind of the etiology of shock, it comes in basically four categories. Cardiogenic, meaning that it's got something to do with cardiac output and the loss of the ability to adequately provide for blood pressure. And under that can be MIs or cardiomyopathy, so that's the contractility of the myocardium. Valvular heart disease, so the inability for the blood to be delivered to the cardiovascular system. Ventricular rupture can happen. Congenital heart defects. Papillary muscles, chordae tendineae problems, so then you end up with prolapses of valves. That kind of goes with valvular problems. All of these things, blood pressure drops, cardiogenic shock, because it's a problem of the heart. Obstructive shock is when there's something not allowing the heart to do its thing. So pulmonary embolisms, for instance, cardiac tamponade, tension pneumothorax, a dissecting aortic aneurysm, which we're going to talk about soon. All of these things prevent adequate blood flow. Hypovolumic shock is when you are losing fluid and the blood pressure drops because there's not enough fluid. So that could be things like hemorrhage. That's a very common one. Dehydration, vomiting, diarrhea. Overuse of diuretics, people overdose on that. Burns are an interesting cause of hypovolemic shock. It's because especially large burns, they fill up with fluid, and you actually lose that fluid from the interstitium and into the blisters of the burn, and that can lower blood pressure. Pancreatitis, very big. So distributive shock is things like anaphylactic shock, head injuries, spinal cord injuries. Sepsis is an important thing. So sepsis is shock because of blood-borne infections. All of these things can lead to circulatory shock. And what that is a loss of perfusion and oxygen. So when you have oxygen, we've talked about this enough already, but it's really ischemia. When you have not enough oxygen, you have cellular hypoxia, you end up with anaerobic respiration because you're trying to make ATP. You don't have enough oxygen to do it aerobically, so that you end up doing it anaerobically, which leaves you short of ATP because you're only making 2 instead of 36. It also leads to the buildup of lactic acid, and so you can end up with a metabolic acidosis out of this, and you may not have enough ATP to adequately maintain the sodium potassium pumps, and you end up with things like hydropic swelling and such, and cellular injury if we go back to the first units of this course. Another thing that happens with lack of oxygen is more free radicals. Now, free radicals is a term that probably gets thrown around a lot. From a chemistry point of view, a free radical is any atom that has an unpaired electron in its valence shell. And really what that means, as far as you're concerned, that is a very, very, very highly reactive molecule. Like that atom without the looking to pair its unpaired electron is going to react with anything that can make it stable and pair the electrons. So that's going to really screw up the chemistry of your metabolism and can lead to some really spectacular metabolic failures. Another thing that happens in hypoxia is that macrophages start coming, and it induces the formation of monocytes and the migration of macrophages, and macrophages to try and clean things up, but can cause damage and inflammation. The coagulation factors can go way up too. You end up with stasis of the blood, and so some of the intrinsic coagulation factors can be triggered. Not so much the extrinsic ones, but the intrinsic ones. Although extrinsic ones can also be because of the damage of the deoxygenated tissue. So it gets very complicated, but it all adds up to not enough ATP, tissue damage, because of tissue damage, more apt for coagulation, and macrophages and inflammation. So none of it sounds particularly good. So this is a diagram, a chart that you can follow along, and for those of you that enjoy it, enjoy. You can just follow all the steps. Hypervolemia leads to decreased cardiac output, impaired oxygen, cellular hypoxia, which gives you anaerobic with less ATP, less sodium potassium pump, hydropic swelling, impaired integrity, cell death. More free radicals, cell death. macrophage induction, release of cytokines, um, uh, more inflammation, releasing an enzyme, cell death, uh, etc. And some of it actually feeds back, and you end up with these positive feedback things. So like pump failure because of acidosis, and decreased cardiac output because of vascular dysregulation, and this thing will exacerbate itself. So obviously there will be an allostatic response to this. There will be an attempt to put this back to right and get back to homeostatic mechanisms. And so this is allostasis in its most primal form. This is how we're going to try and fix this. So the first stage is the compensatory stage, and this is when the allostatic mechanisms are actually going to work. You're going to end up with adequate tissue perfusion. If it's a cardiogenic and you have a low cardiac output, well, then you're going to increase peripheral resistance and maintain perfusion that way. It's most of the compensatory stuff revolves around the sympathetic nervous system. So this is really allostasis, and it works for the short term. These mechanisms are not designed to work for the long term. Now, if the underlying problem corrects itself during this compensatory stage, then Bob's your uncle and everything's good, right? If the underlying mechanisms do not correct during the compensatory stage, then things progress. And we call this the progressive stage of shock. This is when the allostatic mechanisms no longer can keep things in the homeostatic ranges. And so you start to get hypotension and hypoxia. And with the hypotension and hypoxia, you're going to end up with more lactic acid. You're going to end up with hydropic swelling, cellular dysfunction, membrane integrity, and eventually cell death. You're going to have the free radicals, inflammation, and activation of clotting, which I have already gone over. Now, in this progressive stage of shock, this is where medical intervention can hopefully put it back at least to the compensatory, and the interventions can also address the underlying mechanisms of the shock and the causes, and therefore the person can recover. If the medical interventions can't do that, then things end up in the refractory shock, and the person doesn't respond to the medical interventions. And usually this is the beginning of the end. This is not a good place to be. It probably results not only in cellular death, but organism death. And the person will probably pass. So this is a table comparing cardiogenic and hypovolemic shock, septic shock, and some of the clinical findings, the clinical manifestations, so that all of them have hypotension. Septic shock has low resistance, whereas the other two have high resistance. And because then it's low resistance, septic has high cardiac output and preload, etc. So if you just follow along, it makes sense. And if you're going to use a table like this, and when you use a table like this, it's a good idea to really think about why. Ask the question why in each one of those things. So cardiogenic has hypotension because cardiac output is down. And you see cardiac output is down. in order to try and maintain blood pressure, then vascular resistance has to be high. When vascular resistance is high, then the preload ends up high. The veins carry very deoxygenated blood because you are delivering the majority of the oxygen at the capillaries from the arteries, or the arterioles. In normal, there's enough reserve, and there's still a fair amount of oxygen in the veins. Urine output is low because you are trying to maintain blood pressure up, and you don't waste any blood on the skin, so the skin is cool, etc. So you can go through that on your own, and it's a good exercise. Again, if you like this kind of diagram, enjoy. So now we're going to look at the different types of shock. We're going to spend more time on the cardiogenic and the hypovolemic because this is what we're really going to see. So cardiogenic shock is when the ventricles fail to pump enough blood to adequately cause perfusion, to create enough blood pressure to cause the perfusion that you need. It can be left, it can be right, or it can be both, but it's still cardiogenic. So there's some sort of ventricular dysfunction. Usually it's heart attack. It's usually MIs that do it. You're going to get a decreased cardiac output because of decreased contractility and decreased stroke volume. You're going to get elevated end diastolic pressure. So that's because the blood is being returned, and so you're going to end up with an elevated systolic as well, but and systolic, but you're going to have lots of filling. It's going to sound distinctive, and it's really kind of left-sided heart failure because you're not adequately doing what needs to be done. So then that'll lead to pulmonary edema in much the same way that left-sided heart failure does. So again, myocardial failure, less stroke volume in ejection, increased end systolic volume, which then increases the preload, more pressure in the atrium, then it backs up to the pulmonary. You get pulmonary edema, hypovolemia, which then hurts the myocardium more. So you get an increased afterload, blah, blah, blah. And if you can follow this all along, where you end up with is progressive shock. So the hypovolemic is sometimes called hemorrhagic because hemorrhage is an important cause of it. I prefer the term hypovolemic because that accounts for any loss of fluids. Hemorrhage really is the loss of blood. So this is any loss of fluids to burns, dehydration, fluid leaking out, could be drainage issues, things like that. It all will result in a low cardiac output, which will then be compensated for by the sympathetic nervous system. But there's just a logic to this, and it makes perfect sense, right? That you lose volume, which decreases preload, which decreases cardiac output because stroke volume goes down, which then means blood pressure goes down, So you try and compensate with heart rate going up, and when that progresses, so you can no longer do that, then you get decreased tissue perfusion, hypoxic cell injury, and shock. And the shock decreases cardiac output more, and it becomes exacerbating itself. So a little bit of loss will lead down this path. More loss it increases the severity of these symptoms. So really, what are you going to try and do? Is you're going to try and do fluid replacement and control the source of volume loss. So sometimes people are hemorrhaging internally. Spleen is ruptured and bleeding. So that takes a surgical repair. It doesn't necessarily have to be like a desanguination outside. It doesn't have to be a laceration. It could be an ulcer, a stomach ulcer, and a bleed that way. It could, could be burns, all kinds of things like that. And so you try and replace with whatever you can. It could be blood products, various colloids, just fluids, all kinds of things. But that's the way that it needs to be treated. So, so these are the tables and how we class it. So at first it's a class 1, and you get some tachycardia, and it's the compensatory. This is you get an increased pulse pressure. The reason that you get an increased pulse pressure is because the lack of volume means that the diastolic blood pressure goes down, which means the systolic blood pressure goes up to compensate so that the mean arterial pressure is normalized. This is all compensatory. So really what you're going to see is some blood loss, a little bit of increased heart rate to increased cardiac output, and an increased blood pulse pressure because the diastolic drops. As you're still compensating, you end up with rapid breathing and tachycardia. Then the pulse pressure starts to go, and you start to shunt blood away from the skin, and delayed refill. People start to know there's something wrong and have some anxiety. But anxiety increases the tachycardia and tachypnea. So it starts to progress. You stop making urine. And not enough ATP going on in the central nervous system, confusion, agitation. In the refractory stage, you've lost a lot of blood and narrowed pulse pressure, loss of consciousness, cold skin, and who knows where that's going to go. So you can, this figure talks about all of that stuff. Okay, the last topic for this section is altered blood flow. And really, these are alterations in blood vessels. So a lot of them are structural alterations. So a structural alteration that's going to affect blood flow in veins would be valvular incompetence, so varicosities. Arteriosclerosis, atherosclerosis. If you don't remember the difference of those, please review it. Arteriosclerosis is the more general term. Hardening of the arteries, thickening and hardening of the arteries. Atherosclerosis is got more to do with plaque and foam cells, that kind of thing. Aneurysms are weakness, out pockets, usually on the arterial side. Arteriovenous fistulas, where the arteries and the veins form an anastomosis inappropriately, and flow will happen from the artery into the vein along the pressure gradient without the intervening capillaries, and so that can severely alter blood flow and pathways of flow and things like that. On the arterial side, we can have obstructive problems like the arteriosclerosis. Inflammation can do it. Vasospasm is a big deal. As you remember from AMP and hemostasis, vascular spasm is the first stage after tissue injury of a blood vessel. So vasospasm will severely limit blood flow past it. Different thrombi, clots, and emboli, dislodged clots or fat emboli, things like that, can have a major obstruction in arterial flow. Now, we talked about them when we talked about emboli, pulmonary emboli and things, but really the same mechanism goes to any capillary bed on this systemic side. It's just not quite as life-threatening, but that's going to alter arterial flow, and especially to the region supplied by that. Acute occlusions will do it. The fistulas, which are really arteriovenous anastomosis. Aneurysms, which we're going to look at a picture of 2 slides from now. So the aneurysms are these local dilations in the arterial wall, and arteries are high pressure vessels, and they need to contain the pressure. And when the wall weakens, the area can rupture. So most of them are true aneurysms, where the entire wall gets dilated. False aneurysms are when there's a break in the intima, and blood can get behind the tunica intima into the tunica media and cause a bulging of the artery, but the laminar flow through the artery itself isn't terribly disrupted. It looks like an aneurysm, but it doesn't act like an aneurysm. It's not particularly a weak spot. But this dissecting aneurysm means that damaged tunica intima can lead to thrombus and emboli formation, and so can be quite dangerous, but not hemorrhagically dangerous, more in thrombic danger. The places where these are commonly found also happen to be the places that are most dangerous. I sometimes wonder whether they're more commonly found in cerebral circulation and abdominal aortic situations is because those are the life-threatening ones, and those are the ones then we look for, and we don't tend to see the ones that are in the in the celiac arteries or the superior mesenteric artery or something. I don't think I've ever heard of anybody that had an aneurysm, a berry aneurysm or something in their fingertip, because we wouldn't worry about it. So we would never even label it like that. But nevertheless, that's where we find them. And aortic and abdominal are really quite dangerous. Like the abdominal aorta, because all of your blood flows through there. It's under huge pressure, and a leak there, a dissecting and a leaky one there, means that you can bleed to death in very short order, and they're a medical emergency. My uncle was downtown. He was at the bank in Timmins, where he lived, and he had parked his car right across the street from the bank, which happened to be right in front of the Emerge entrance to the local hospital. And he kind of hastened across the street, and he had an aneurysm, an aortic aneurysm anyways. Felt really funny, felt faint. As he was going to get into the car, decided, oh, maybe I'll go to the hospital, and then walked into Emerge and fell because he was bleeding so bad, and he had surgery like within minutes of that. Luckily, the triage nurse recognized what was going on right away. She knew him and recognized right away what was going on, and they had him in surgery in literally minutes, and they saved him from bleeding out, which was really an incredible thing. A lot of elderly men that drop dead because of a aortic aneurysm bleeding out. A lot of strokes are caused by aneurysms in the cerebral circulation, dissecting or leaking. So when we look at it, the true aneurysms are the ones that where the wall is entirely bulged out, right from including the intima. So the saccular ones are one-sided, the fusiform ones are all the way around. False aneurysms are when there's a leak behind the intima and it bulges out. Dissecting is like this. So this concludes the unit, and we will continue with Unit 9 in the next videos.